I don't think there's any doubt that the name of the game for us is to get people seizure-free without side effects of medication. And I don't think there's any doubt either that we don't always succeed, and often we try very hard by not succeeding not to make people's lives worse. So I looked at this a little bit differently. I sort of thought, is there any data to actually support the suggestion that if you keep trying, you will succeed at least in some situations, rather than make the argument, which I think is an easy one, and that is we want everybody to be seizure-free. And we know we can't get that. So I'm going to show you what I have, which is, I don't think, a lot, and I don't think, there's a lot of data in the literature. I'm also going to use the opportunity of you giving me this 15 minutes to show you my latest outcome data, because it is relevant to the answer to the question, and you saw some people mention it. And so in a way, it's about what are we trying to do? What difference are we trying to make with people with epilepsy? How can we get as many people as possible seizure-free? And you know about puddings. Here's another pudding. You've heard about the puddings in the morning. Here's another pudding, which to me answers all the questions in a single individual, a single patient, because it was her strategy to become seizure-free, and it was my strategy to get her seizure-free, despite the fact lots of people had tried. And she was an unusual case with startle-induced myoclonic and tonic seizures of her left leg. EEG was supportive of something there. MRI didn't show anything. Video telemetry didn't suggest there was anything we could operate on. And this was the neurologist who referred her to me. If she is sitting, she will jerk to the left, and her left leg would jerk. If she is standing, she will fall forward straight to the ground, often injuring herself. Falls occur 3 times a day, and this makes it pretty much impossible for her to lead any kind of life. She came in wheeled by her family in a wheelchair. I think she was 25 at the time, unable to get up, unable to walk, a nice, attractive young lady. She tried all the drugs, and she was on carbamazepine, gabapentin, topiramate, and clonazepam when I saw her, having failed a range of other anti-epileptic drugs. We tried everything over the years as the new drugs became available. She did a little bit better on zonisamide, but still couldn't walk. She failed the other drugs that I had available as they came through, and when retigabine, the potassium channel opener, became available, we started that on June 2012. And she was seizure-free since August 2013 on it, and she had a new life. She walked about, she was taking driving lessons, she got a job, etc., etc. And then, of course, retigabine was due to be withdrawn in 2017. And so we tried to make a game plan. I tried the only other drug that she hadn't had, perampanel. We introduced it slowly over a period of months. I titrated it to the maximum tolerability, and that was 8 milligrams twice daily, and then we slowly withdrew the retigabine, and for whatever reason or other, she's still seizure-free, and she's on 5 anti-epileptic drugs. So, and I believe her. I don't think she has anything other than epilepsy. So this is an unusual case, but this is the point. You must keep trying, and you can succeed. This is the older chap I showed you, and just to remind you, there's different reasons. One is efficacy, patients not being seizure-free because drugs don't work, others because they don't tolerate it. And this was the old boy on phenobarbital and primidone, whom we tried a whole range of different medications, and they had side effects. So obviously, if a patient's not tolerating the drug, you change it, and you're more optimistic that you're going to get them seizure-free with the next one. So I think it's easier, that's an easier scenario than when they tolerate it and it doesn't work. If they don't tolerate it, then you do try other drugs, and you do try other drugs with different mechanisms, as we said. And this chap got all the appropriate side effects for the medications that we tried and ended up again on 3 drugs, but the esclicarbazepine, the sodium channel blocker, did the trick. And this again was in a fairly high dose. So if they don't tolerate it, I think it's easier to actually go forward and try different drugs than if it doesn't work. This is a lady that was sent to me. A lot of the difficult cases are sent to the clinic, and lots of things have been done. She had prolonged right-sided febrile convulsions at the age of 13 months, focal seizures affecting her right arm, and reduced awareness at age 5. When she came to me, she was on carbamazepine, lamotrigine, and perampanel, having failed virtually everything that was available. Not everything, but most things. MRI showed a small left hippocampus, an EEG inappropriate focus. The surgical guys were not keen to operate on her, which was a great disappointment to me. I suspect if I sent her somewhere else, they might well have done, but they didn't in Glasgow. And so she was sent to me. And I went through pages and pages and pages of information. At the time, she was having 6 to 8 seizures a month with a catamenial component. She was having them particularly before menstruation. She worked as a leisure attendant and didn't have a partner. And I looked up all the other things that she's had. We tried the levetiracetam because I wasn't sure whether she had a good trial of it, but she didn't tolerate it. And the only other thing she hadn't had was a combination of valproate and lamotrigine. And so, touch wood, she's been seizure-free for a little while now. I expect her to relapse at some point on high-dose carbamazepine, lamotrigine, perampanel, and valproate chrono. So this was the only thing that she hadn't had, and she's got a different quality of life. And she accepted all the risks of the valproate and the high doses, and we went through this in some detail. And she didn't plan to get married. Her inclinations were elsewhere, and this arguably helped because that was the only thing I could find that she hadn't really had a chance to. So again, if you don't give in, every now and again you get a pleasant surprise. These are all, of course, the drugs that we have had over the last 20 years or so. And we think we've got lots of mechanisms of action, and we think we're looking at different drugs when we treat different patients. And we talked about mechanism on the other talk. But the bottom line is, of course, these are anti-seizure drugs. They are not anti-epilepsy drugs. They treat the seizures, not the cause of the seizures, and the epilepsy progresses and the seizures get worse. And so it's perhaps not surprising that we struggle in so many patients because we are not treating the cause of the problem. So in a way, what we're thinking is, are these anti-epileptic drugs genuinely different? Are the mechanisms genuinely different? Or are they just the same thing that looks a little different? They're all footwear, and I suspect most of our anti-epileptic drugs are all footwear. So this is the end of the story, and I've got about 5 minutes just to show you these data and show you how they're relevant to the discussion that we're having. This is the paper that was published just this month in JAMA Neurology, looking at 1,795 newly diagnosed patients followed up for up to 30 years. All of them were followed up for at least 2 years. Everybody knows the approach that we take, and everybody knows the results. This was the slide you saw before, which is my colleague Ben Chen cleverly made up because it shows the way we moved away from drugs and for other drugs. The green is carbamazepine, and it's virtually disappeared because I don't use it at all now. This is over since 1982 to 2014. You can see we still use valproate, although less. That's the mauve, if you like. And at the top is phenytoin, which is gone. And here you have the new drugs above the line. And you can see a lot of it is lamotrigine, a lot of it is levetiracetam, and all the new drugs we use to some extent. So we're able to prove that we actually changed our clinical practice from the old drugs to the new drugs. And now the question is, did they make a difference to outcome? So when you look at different populations every 10 years, this is the cumulative probability of seizure freedom in the first 10 years on all the patients with all the drugs available. This is in the first 20 years with all the new drugs, including lamotrigine and topiramate and other drugs. And this is the total group over 30 years. Convinced? Not a difference in outcome, despite all these drugs which are not necessarily different as we think. Now, like all the other studies that we published, after the first, second, and maybe third schedule, we got very few patients seizure-free. You can see the white bits at the top are the seizure-free patients up to the third, fourth, fifth, sixth, or seventh schedule. So why does that encourage me to think we should carry on treating these difficult patients and hope for a better outcome? Well, when you actually look at the number of patients who are seizure-free, because not all the patients actually got a fifth, sixth, or seventh schedule. So 14% of patients who got a fifth schedule, 14% of patients who got a sixth schedule, 7% of patients who got a seventh schedule are seizure-free. That's worth it, is it not? The reason that we don't go there all the time is we probably poisoned the patients up to that point, so they don't want any more drugs. So if we take back the drugs we've given them and push on with the other drugs they haven't had in incremental dosing, we are going to get more people seizure-free. So this is, as far as I'm aware, the best data in the literature to suggest that it is worth persevering and you don't necessarily need to give up. And we have to start damage limiting after the first and second drug and not wait until they're on 4 or 5 drugs and their eyes cross and they can't see it and they can't speak. And of course, the bottom line is, after all these years, comparing to our first analysis published in New England Journal, which is cited more than 4,000 times, and everybody cites it, we had 64% of patients seizure-free. And after all these years and all these extra drugs, we have 64% of patients seizure-free. So that's my life in one slide. You know, at least I know the answer to the question. We haven't solved the problem, but at least we know where the answer is leading us to. And you can see what happens is that patients on monotherapy end up in polypharmacy and then they relapse. And patients, so the new anti-seizure drugs do stop seizures for a while, but not in everybody. So we're slowly reducing the monotherapy patients and slowly increasing the polytherapy patients. So again, that makes sense as you look to the natural history of treated epilepsy, that it is a progressive disorder in some people. In others, it goes away and we treat it and there's no problem. They're on one drug, they might be 500 milligrams of valproate, and that's perfect. But the ones who are difficult, the ones with progressive epilepsy, often focal seizures, they just slowly progress, or many of them do, and we lose control. So, what did Gowers know that I didn't know? Because he claimed he was getting 70% of patients seizure-free. And we don't get 70% of patients seizure-free. And that suggested to Alan Hauser, who wrote an editorial to accompany the paper in JAMA Neurology, that maybe there's a ceiling to control. Maybe there's just some patients you can control and others you never will control, or at least you won't control them long term. And I think that does make sense, considering the range of underlying pathophysiological and pathological processes in these individuals. So if you want to make people have the best quality of life, as I showed you before, these are very important signs. You need to make them seizure-free, not 1 a month, not 1 or 3 months, not even 1 a year. There's evidence to support that. And of course, what you need to do is make sure you're not poisoning them while you're trying to get them seizure-free. And this is, again, is crucial, because this is what we do. We push the dose and we push the dose, and then we add another drug, and then we add another drug, and we wonder why they don't tolerate it. And we don't give ourselves a chance of making people seizure-free in a way that arguably we should. So, despite overall unchanged outcomes over the past 25 years with the introduction of a range of new anti-seizure drugs possessing different mechanisms of action, the prognosis for the individual patient should always be hopeful, and seizure freedom should never be regarded as an unrealistic goal. And the moral of the tale is, never give up. Work with the person, work with the family, and see if you can find some way to get them seizure-free, or at least damage limit the best way you can. But it's no harm to take a break, and sometimes I say to my patients, go away and come back next year and we'll have another look, and we'll see how we get on with that. So to me, it's an easy question. You cannot give up. The patient might give up, but I won't. Thank you.